Hello students, my name is Moon and this is He200, otherwise known as the EMT class here at Queensborough Community College. And we have two chapters lined up for tonight, which is anaphylaxis and toxicology, or immunology and toxicology. But when you pull up the immunology chapter, all you see is the allergic reaction, what's going on. And yes, immunology, or the study of the immune system, is a gigantic field. However, we're not interested in most of that. As an EMT on scene, the only thing we can do immunology wise is address allergic reaction. And allergic reaction can really be a life threat. This is allergic reaction among the immunology category of diseases is the life threat. Yeah, people can die of other kinds of immune system collapse, but those take a while to develop, and by that time the caregiver has already taken the patient to the hospital. This is the one that can develop in hours and maybe even minutes, and then 911 is absolutely necessary. Okay, so the allergic reaction is part of the immune system. The immune system is the defenses of your body. And you may think, well, allergic reactions, you mean like pollen and mosquito bites, and for the unlucky few, like peanut allergies, cat and dog allergies. How is that the immune system? What's happening is that there's been a tragic, horrible misunderstanding. Your immune system targets specific molecules. What's a molecule? It's a tiny, tiny string of atoms, and we're all made of molecules. So every surface in our body, inside and outside, is made of molecules of an immense variety. But there are some molecules that are associated with that have only been seen in invaders. So dangerous pathogenic microbial life like bacteria, viruses, parasites. And so our immune system evolved to recognize those. It's kind of like when the police take a snapshot of a perpetrator, a suspect, and then sends the copies of this picture to all areas of the country and say, be on the lookout, wanted, dead or alive. Whenever you see this person, respond appropriately. And that's how our immune system works. But sometimes, and our bodies are not perfect, life is not perfect, sometimes there's a mistake. And have you ever been in a car and you have you ever owned a car and then one day you get a letter in the mail and it's a speed camera saying that we caught you speeding at this time, at this place. You owe us $50. And you're like, I was there, but there was no way I was speeding. And you look at the picture and it took your car, but you distinctly remember I was not speeding at the time. And what happened was somebody else was speeding and it triggered the speed camera, but for some reason the camera zoomed in on you, your license plate, and it's saying you're the one who's speeding, now you owe us money. How you deal with that? Well, it's just beyond the scope of this class, but it's kind of like what happened here. Somehow along the way, your immune system, or this patient's immune system, detected a pollen molecule or a pet dander molecule or a peanut molecule or a gluten molecule, and said, that's the enemy. That is a molecule that's only seen in invaders. We must attack. And if other parts of your body say, what are you talking about? It's an innocent bystander. That's not going to cause any problem. But your immune system is now convinced. Like from now on, anytime you see this molecule, sound the alarm, we'll go on the attack, throw up all the defenses, and no matter what it takes, we have to save the body. That's an allergic reaction. Sometimes the allergic reaction is minor, like every time I get a mosquito bite, it's a little bit of swelling, it's a horrible itching. But then I put a little hydrocortisone on and it goes away in a few minutes. And so, thank goodness for modern pharmaceuticals. But sometimes it's very serious in that it can actually cause a life threat. So when it's a life threat, the antibodies is the fancy term for what I just explained. And when it causes a life threat, then we call it anaphylaxis. Okay, well, let's go through these slides. So the antibodies is how it sends out patrols and stays on the lookout for the perpetrator, the most wanted sign, dead or alive, some guy's face, and that's the antibodies are looking for that guy's face or this pathogen's molecules, surface molecules. One of the things that happens when a match is made where it thinks it detects an invader is it sends out alarm signals, many different kinds of alarm signals, and histamine is one of them. This is why during pollen season, during hay fever season, when you are hit especially bad, just like me every spring, we run to the drugstore and we go buy ourselves some antihistamines, because we know that all of these symptoms we're having during pollen season is not a sign of an actual infection. No, we're just overreacting to the pollen in the air, the different kinds of pollens. And so we take an antihistamine to hopefully make our lives a little more bearable. Okay. So sending out alarm signals is one of the immune reactions to defend the body. So when these alarm signals go out, what happens? Redness, pain, and swelling, inflammation, bronchoconstriction, and vasodilation. For some of you, these are brand new terms. I'm not sure why, because I explained each one of these in the anatomy, chapter 6. But to help illuminate this idea, let's bring up our bright space. Here is bright space. You know what? Let's go over from the, let me expand this a little bit, fit the screen, making sure it's center for YouTube purposes. Let me go down to R13. So you're used to clicking on M13. These are my other classes, don't worry about it. Let's click on R13 and then content, the nav bar, and let's go to handouts assessment, and you'll notice that there are now two more files here. Let's click on what microbes want. Here's a little cartoon I drew, and let me zoom in a little to make it easier to see. And inflammation. This is a PDF, so it's not clickable. Anyway, inflammation, which is redness, pain, and swelling, fever, mucus. Here's the pain again. These are not caused by the infectious organism. This is a misunderstanding among the general public. The infectious organism does not cause this. Your body causes this. Why would your body cause you so much suffering and pain and suffering? It goes a little something like this. A microbe wants the same things you want, which is a place to stay, enough to eat, somewhere warm and dark and moist, so it can live a good life and it can provide for its offspring. So here's a little, as this microbe is dividing, it's going to create little offspring of its own. So it wants a nice safe place for the next generation. It wants to do the same things that humans do, which is multiply, go forth and multiply, and make a future for themselves. The problem is that's the things it wants, the things it needs to use to do these things is the same thing you need, your body. It's using your body, it's using your oxygen, it's using your glucose, it's using your proteins, it's using everything in your body to get what it wants, and so now there's a conflict. It would be nice if we could just all get along and learn to share, but the analogy falls apart here. The microbes are not that smart. They're not conscientious. They're not willing. They're not capable of negotiating. They're just going to take and take and take as they grow and grow and grow in your body. So that's it. We have come to a point, a non-negotiable point. We have a point of irreconcilable differences, and your body is saying, I'm sorry, but you can't do that here. I want you out, or I'm going to get rid of you. So the successful microbes will try its best not to get noticed. And that's why the microbes, the infectious microorganisms, do not cause inflammation, fever, mucus, pain. They don't want to cause anything. They want to stay on the down low. Here's a white blood cell on patrol. Remember, white blood cell is part of the immune system too. And they don't want to be noticed. They're going to sneak around, stay under cover, of course, eat and poop into your body, but otherwise try to get away with it. But eventually they will multiply so much, they will grow so much that eventually they can't not be noticed. They can't not be not noticed. They will be detected, and then the alarm signal comes out. So the histamines, not white blood cells, but another part of the immune system launches histamines, and histamines trigger all of these things. They cause the pain. So I can understand. It's understandable if you think pain is just bad, and pain, we should live our lives completely free of pain. That would be nice, but pain is a tool. Remember, pain is a tool. Back in more than 100,000 years ago, when we were hunter-gatherers, long before there were hospitals, long before there were drugstores, long before there were smart people, there were just survivalists, hunter-gatherers, and we didn't have any knowledge about how our body does what it does. Pain was a very valuable tool. Pain was our body's way of saying, whatever you just did, don't do that again, or something's wrong. Pain is an indicator to say, I need your attention here, because something is wrong here. What else is there? Inflammation. Now, maybe I should have drawn this guy as a soldier, as an invading soldier, because what do you do when the enemy is invading your country? Well, you send out the troops. How do you get the troops there? Well, you have to carry them there in trucks, in tanks, in airplanes. But in order for the trucks and tanks to go there, and we need a place for airplanes to land and refuel, we need airports. But in order to increase all of this infrastructure, we need roads. So inflammation is the expansion of roads in the body to the trouble area. What are roads in the body? The blood vessels, arteries, veins. So the arteries and veins dilate to that area. More fluid is sent to that area, and when there's more fluid in the same amount of space, you're going to get pressure. All of this extra stuff showing up in the same place is going to take up space. It needs to be put somewhere, and so there is swelling. So we've got the pain and the swelling. Oh, what's the redness? Well, more and more, or larger and larger blood vessels going to the area, it means more and more red blood cells. Well, what color are red blood cells? Red. So more and more tiny red dots coming into the space will make the entire area look more red from the macroscopic view. From the unaided human eye, the area of the body looks more red. So there's your redness, pain, and swelling, and that is inflammation. What's this fever? Isn't the invading army setting fire to the land? No, your body generates fever as a defense mechanism. Fever is a defense mechanism. This is the idea. A microbe that is so well adapted to living in the body means it has itself an optimal temperature of our temperature, which is 98.6 degrees Fahrenheit, 37 degrees Celsius. So that's the temperature it would rather be at, and the body's strategy, one of them, is to increase the fever, turn up the thermostat, hoping that as the body gets warmer and warmer and then hot and hotter, it'll start killing the microbes. How hot does fever get? Well, technically over 100.4 degrees Fahrenheit is a fever, but you may have heard of some really concerning, serious situations where it can go to 102 degrees Fahrenheit. When it's up to 104, definitely anybody at 104 definitely needs to go to the hospital on that number alone. Under that, take it in context. By the time somebody gets up to 104, they probably have these other things going on. All right, so you are at, there's fever. If it's a respiratory infection, then you may have noticed that you fill up with mucus, phlegm. Your throat gets all sticky and creates this gooey stuff. Doesn't the microbe make mucus? No, your body makes mucus. It's drowning the infectious organism in mucus so it don't go nowhere. And also in our respiratory system, in our airways, in our lower airways, the mucus sticks to the mucus causes everything to stick to it. Dirt, oils, and microbes, microbial life forms. And then the cilia in our airways act like a conveyor belt and move all of that gunk up to our pharynx. You know what a pharynx is by now, right? And where you feel its presence, and you reflexively swallow. It's all right. It's more protein. You're going to recycle the mucus. You get more protein. Everybody wins, except this guy. But if you are in a more socially acceptable location, you can spit it out, which probably most of you would rather do. So these are all parts of the immune system. They're not created by the microbe. So what are these little doohickeys here? These little things sticking out of his body that weren't there before. Let's zoom in a little bit. Yeah. I thought I would be able. I would zoom that would zoom me in. Can we do it this way? Let me go back to this. I'm recording from my home because of our special Queensboro schedule. Let's get back to where we were. And now let me download instead of view. Let me download. It's all the whole point of this little maneuver was so I can get back here and then I can zoom in like that. Probably was a faster way to do this, but what are these little things here? These Y-shaped things here. Does anybody know? If you know, then send me an email or bring it up in class. I'm done with this thing. Let's go back to the slideshow. Okay, so that's inflammation. What about bronchoconstriction? Is that a body response? Kind of. Remember this swelling? Let's bring it up here. Remember this, remember this swelling, there's a surface, and then if the vasculature to that area gets pretty, it increases enough, that swelling, right? So here is your skin, and all right. Let's do a complete job of it. So here's your skin, and then there's swelling like that. Okay, so that makes sense, right? Well, now what if, and this is on top of the skin, what if horizontal. What if this swelling is happening in your throat, in your airway? Air is trying to move in and out of your airway, but this swelling now is making it harder and harder to breathe. That's constriction. We call this constriction, and that's bronchoconstriction. Vasodilation is the fancy term for expanding your arteries and veins so more stuff flows. But if it's a localized vasodilation, it causes a bump and it causes itchiness, as well as histamine causing itchiness, which is why an antihistamine is also great for mosquito bites too. But don't take an oral antihistamine for mosquito bites, because the onset time for oral antihistamines is an hour to 2 hours, and by then the mosquito bite has already worn away anyway. So that's going off. All right, so anaphylaxis. Anaphylaxis, everything we just talked about, but the amounts are so much that it's actually threatening life. Well, we already saw an example of swelling threatening life. If the swelling is happening in the throat and it's blocking the airway, then it's threatening life. What about this vasodilation? Okay, if the vasodilation is happening in a small area of the body, okay, that's swelling, it's painful, it's itchy, big deal. But if it's happening everywhere in the body, then the same amount of blood, but in a larger container, hypotension. So that is called anaphylactic shock. Airway obstruction, we already talked about. And eventually, if this bronchoconstriction gets bad enough, then it results in respiratory failure as air is not moving. Okay, so what kinds of things can cause an allergic reaction? All of this, the usual stuff, right? And it's a picture of that from your textbook. Great. I don't know why this slide keeps coming up. It's really hard to find latex gloves, but every not only EMT but every health class warns the students not to buy latex gloves. But that is so well known now that you can't buy latex gloves now. See, every time I'm searching for latex gloves to buy, and this one says latex free. Oh, this is latex gloves. Interesting. Okay, so I thought latex gloves are just not available for sale anymore because of the famous allergic reaction potential. But apparently you can. I used to tell students that the only place you'll find latex gloves these days is in a museum. All right, well, maybe that's why it's in the slide. Maybe if you happen to work for a rare ambulance agency or hospital that still has it, then you're not supposed to use it. But then why would the ambulance agency and hospital buy these? Okay, so anyway, don't wear latex for your patient. There is a non-zero risk of latex allergy for the patient. By the way, with medication allergies, there's no way to predict it. Remember how the allergic reaction formed in the first place? There was a horrible misunderstanding, a tragic misunderstanding. Nobody plans to have a misunderstanding. Misunderstandings happen accidentally, randomly. So there's no way to predict if somebody will have an allergic reaction to a medication unless they've had one before in the same category, in the same class. And that's why the doctor needs to know if the patient has had any allergies in the past. Back to here. No way to predict. And also there's no way to predict the course of an allergic reaction. What does course mean? How fast it grows, where it grows to. Once somebody calls 911 for an allergic reaction, it means that it's bad enough that it made them worried that they may need to go to the hospital. It is not a small thing anymore, so take him to the hospital. Even if it seems minor when you got there, it could progress rapidly. So try not to let them stay home. Try to convince them to go to the hospital. So signs and symptoms, there's itching, which is the medical term. The medical name for itching is pruritus, and I don't know why EMT classes always leave this out. They always emphasize this. Every EMT class tries to make sure you understand that hives or swelling is urticaria, but they never mention pruritus. But for me, a mosquito bite, which is an allergic reaction, causes severe pruritus for me, which is why I'm traumatized by mosquitoes. Swelling of the skin makes it red. Swelling of the face makes cosmetic issues. But the problem now is, if they're swelling in the face, then they may be swelling in the mouth, and they may be swelling in the throat, and that is anaphylaxis. So here is an unfortunate gentleman with urticaria of the face, flushing of the face. Here is urticaria of the skin. So pay attention now to how it's not even distribution. It's not the entire skin is not the same color. You've got these welts or wheals. Sometimes it's called wheals. And these are splotchy or localized swelling, and that's often seen with or hives. That's the word right there. This is often seen with allergic reaction. You have these hives, and then if it's localized, that's one thing. But then if it's spreading up and down the body, especially if it's spreading up towards the head, that is really concerning. So swelling of the mouth is bad, but here's a certain part of the mouth that's really bad. Okay, so I have that video is here queued up, and you see what's happening to this poor person. The tongue is swelling. Let's see.
We went ahead and did H2 blockers, H1 blockers like Benadryl.
All right, so the doctor is talking, doctor speak. He's talking about the different therapies, medications they can give as mainly in antihistamines, but not the drugstore stuff. This is like powerful prescription antihistamines, trying to get the swelling down. How did this person get a swollen tongue? Well, what happened? Did they try to swallow a bee? Well, that's one way it could happen. But in medicine, there is a famous case that shows up in almost every medical school exam, which is angioedema after medication allergies, and that is lisinopril. Lisinopril is a medication that it's a diuretic. It helps people pee. People take it for high blood pressure. It used to be very commonly given for people fighting high blood pressure, hypertension, but lisinopril was causing so much angioedema that it's gone out of favor. And now the world has moved on to later generation prils. So people usually don't get lisinopril anymore. They get something else that ends in pril. Okay. Swelling. Okay, so I did say that the blood vessels go from normal to wider, but then after they get wider, another thing happens. They get leaky. You see the spaces, the gaps opening up between the cells that make up the capillary. This is a capillary. I can tell it's a capillary because it's only one cell thick, the wall. Anyway, it's getting leaky. The leakiness has a benefit. This is a white blood cell, a kind of white blood cell. It makes it easy for the white blood cell to slip out between the gaps, and the white blood cell's job is to hunt down invaders. So it allows these troops, these soldiers, to go out there to the area of infection and do their job, attack the enemy. But while the white blood cell is slipping out, what else is getting out of the blood vessels? Everything else, especially fluid. So not only is a blood vessel wider to bring more fluid through the blood vessel to the infection area, but it's also allowing fluid to go out of the blood vessel into the surrounding space. So that's doubly bad for losing blood pressure. If this is happening all over the body, because the body, everywhere in the body thinks they're being invaded, then fluid is leaking out of blood vessels everywhere, and that's anaphylactic shock. If it is a respiratory allergic reaction, then the patient will complain of these symptoms here. You can pause this to read this in more detail, but you're really supposed to be reading this from your textbook in way more detail than is on the slide. The patient will complain of tachycardia and lowering of blood pressure. When the blood pressure starts dropping, it's no longer allergic, it is now anaphylactic. Okay. This is, if you read this, it's like, well, the first three sound like hay fever, pollen season, and it's not a coincidence. Pollen season, hay fever is an allergic reaction, is an immune system overreaction to a benign, harmless molecule of pollen. Okay, the sense of impending doom is when we're talking anaphylaxis. The patient is not a medical expert. They may have not had any kind of medical training, but they can feel it. They can feel something is seriously wrong. They feel like they're going to die. When they say, I think I'm going to die, don't trivialize it. Don't laugh at them. Don't minimize their feeling. Don't try to talk them out of it. They could be telling the truth, and it could be literally what's happening. So, how do you know shock is bad enough that it is a life threat? Well, I already talked about that with the compensated, decompensated thing here, right? So handouts, let's go to handouts, shock. And remember this, I showed you in class, the compensated, decompensated. So that is what? Why is there a 5 here? This is a typo. Title saved successfully. Okay. Yeah, compensate, decompensate. So remember that. So review that slide. Doesn't really need an explanation. Okay. So everything here I just explained. Oh, nausea and vomiting. What's going on here? What does this have to do with anaphylaxis? A long time ago, in our ancient past, before hospitals, before drugstores, before witch doctors, before people who pretended they knew what they were doing, your body, if it felt very, very sick, had only one tool, which is to throw up. If your body was sick for any other reason, there's nothing you can do about it except rest. I guess rest. But you didn't have a choice in that. You were just too tired to do anything. But anyway, if it had any other disease, your body could not do anything about it. But if the cause of the bad feeling was because you ate something that was questionable, oh, you know what to do, you throw up. So from that time long ago, we evolved to treat to respond to serious feelings of sickness and illness with nausea, which means that nausea is while it's an important symptom, it's also pretty common in almost any disease. So of course you should ask your patient if they feel nauseous, but the nausea alone is not definitive of a diagnosis. It could be something else causing the nausea. Of course, get a baseline vital sign and then repeat vital sign. How often? How often should you lead check vital signs when somebody who is having an anaphylactic situation? Okay, and so reassess. And anyway, so primary. So what do you do with somebody who is you call for 911, you arrive for the sick, so scene size up, BSI, scene safety, number of patients 1, NOI, nature of illness is allergic reaction, consider additional resources, consider C-spine. On arrival, you notice that you make a general impression, and the general impression includes somebody who apparently is in some kind of respiratory distress. He may seem sick, he may seem weak, and he may or may not have a flushed face or have hives on their face. But anyway, they're asking for your help. Fine. So you approach the patient after the general impression. On the way to approaching the patient, you made your general impression. You ask them what's the matter, and they are alert and oriented and say, I'm having an allergic reaction. You say, I'll take good care of you. What's your name? Hi, my name is Moon. I'm an EMT. There, so the patient is oriented to one thing, and then they told you they're having an allergic reaction, so they're oriented to the other thing. Let's save the time and place for later. Okay, yes, you're supposed to ask those 4 questions, but let's kind of put it off to like the bottom half of this primary. Instead, you want to check the airway, breathing, circulation, and then we're not ready for the secondary yet, so let's go back there. Either check your airway, breathing, circulation, and then you ask, by the way, I know that sounds silly, but I need to ask you, where do you think you are, and what day of the week is it? So depending on those 4, then you now know, is this a stay and play or load and go? You should also think about the ABC D for disability. That's more like if the patient is not responsive, then you can assess them for like a Glasgow Coma scale. And then E for exposure, such as hypothermia, hyperthermia. Okay, so now by the time you get to the A, B, C, D, and E, and now you know if this is a stay and play or load and go, you call the dispatcher, make a transport decision, give a brief EMS report, and we are done with the primary. So now we're ready for the secondary, and now you want to ask questions. You tell your partner, go get me a set of vitals, and while you're waiting the 2 minutes for your partner to finish the set of vitals, you quickly ask them like how they think this is an allergy, and these are the questions you ask. If you're having an allergic reaction, what are you allergic to, and when did you have it? What kinds of things are you feeling? What are you feeling that makes you think you have an allergic reaction? How fast was it moving, and what have you done to make it better or worse? Hey, better or worse? Wait, that sounds familiar. Oh, better or worse was from the OPQRSTI, and the I is interventions too. What have you done to try to make it better? Like, did you try to take a Benadryl? Did you take an antihistamine? Did you drink a glass of water? So if you got a bee sting, then what did you do with the bee sting? Like, did you scrape it off? What did you do to try to fix it? By the time you finish asking those questions, you are told your partner finishes vital signs. So if the blood pressure is too low, that's anaphylaxis. If the patient was not alert and oriented, that is anaphylaxis. Oh yeah, so I is in part of the OPQ-RSTI. Can you ask the OPQ-RSTI for somebody with an allergic reaction? Of course you can. Oh, onset. How did these feelings begin? OP, provoke palliative. Anything you do makes it better or worse. Q, in your own words, tell me what the allergic reaction feels like. So the patient says, I call 911 because I think I'm having an allergic reaction. So the Q is, in your own words, tell me what are the symptoms you were feeling about this allergic reaction that made you think it was an allergic reaction. R, where do you feel it the worst? And then S, on a scale of 1 to 10, 10 is the worst in your life. How bad is this allergic reaction? T, how long ago did it start? How fast is it progressing? I, what did you do? What did you take to try to make it better? Remember, if you memorized OPQ-RSTI with pain, and you say, okay, we'll take good care of you. Oh, how did the pain start? And the patient says, I'm not in pain, I'm having an allergic reaction. And you say, okay, got it. OP, does anything you do make the pain better or worse? And the patient answers, I'm not in pain, I'm having an allergic reaction. And you go, oh, I'm sorry. So QR, can you please point to where the pain is? And the patient, by that time, the patient is going to say, what the hell is wrong with you? You don't know what the hell you're doing. I don't want you to touch me anymore. Get the hell out of my house. I want another EMT. You clearly are incompetent. You see what's going on? Instead, oh, onset. Sir, ma'am, please tell me, how did this allergic reaction start? And then Pete, anything you do makes these feelings better or worse. So change the wording so that it is relevant to what the patient is experiencing. ABCs, deal with the ABCs. If the patient's airway is like really swelling, if by the time you finish the ABCs, you are really worried that their airway is swelling shut, then part of your EMS report, your transport decision is you need to call for paramedics. Ask the dispatcher, can I get an ETA on EMS? Because this person may need to be intubated before they get to the hospital. Should you give them oxygen? I would. If their airway is slowly swelling shut, then you want to get as much oxygen to their body as you can while you can. While you are, and then hopefully the paramedics will arrive before it's too late. At some point you may have to use a BVM, but that is because you assessed the breathing and saw that they were breathing inadequately. Okay, so auto injector, this thingy, where is it? Oh, did I jump right over the picture? There was a picture of the auto injector, the EpiPen. There it is, the EpiPen. All right, so what slides did I just zoom over? Let's go back. Auto injector, you must get a set of vitals before you use it, and then you must get a set of vitals after you use it. About 2 minutes after you use it, but do not use epinephrine before you use it, because you need a baseline. What if you take blood pressure after you use it and you see a number? Was that number because of the epinephrine, or is that the patient's? Was the patient always like that? How would you know? You would know by taking vital signs before. So, should you use an epi? Should you give the patient an epi? Should you give this person an epi?
is going to show you what a real anaphylactic shock reaction looks like and what happens when someone administers an EpiPen to themselves. Are you ready to watch this incredible video? Let's do it. Anaphylaxis is a severe allergic reaction that can cause the airway to swell and become constricted, making it very difficult to breathe.
Would you give this lady epinephrine? Write down in the comments. Oh, no, there's no. You don't have to comment. It's okay.
You can hear her airway closing up. Usually peanuts, bee stings, and shellfish people have severe allergies to. So she's getting her EpiPen. Now listen.
You saw how she pulled back. I mean, she swung. She wound back and then hit it. She slammed her thigh. I bet one of your skills instructors told you to do that, but remember in lecture I told you you don't have to do that. You don't have to generate that much force. Just position and press. And the patient can wind here. The patient can wind back.
So she's getting her EpiPen.
The patient can wind back because she is in control of her arm. She knows exactly what she's doing. She knows exactly when she'll do it. That's fine. But when you do it to somebody, they may cringe away. They may deflect. They may shift unexpectedly. So when you wind back, that's what you could miss. You could hit somewhere else. So don't wind back, just position.
Now listen. You can hear her airway opening. Her breathing becomes much better. And she literally saved her life by using an EpiPen.
Took 15 seconds. That means that in this amount of time, that's all it took for blood to go from her thigh to her heart, to her lungs, back to her heart, and then up to her throat. It made that long journey in only 15 seconds. Okay, so that was that video, and that was that link, and then here's another link. So it's a good night. This link is a nice overview about how to give it to somebody else. So that's worth a look. And this one, allergic rhinitis. So now, what is allergic rhinitis? Well, rhino means nose, because you know the animal that's a rhino is the animal with a big horn in the nose. So itis is inflammation, redness, pain, and swelling. So nose, redness, pain, and swelling as a result of an allergic reaction. This is not the anaphylaxis, but it is a very common problem. But the reason why I'm showing you this, I recommend this video is because it's a great overview of how allergic reactions in respiratory work. So definitely worth a look. Okay, so you decide to give epi, and how does it work? It dilates the bronchioles. How does it dilate bronchioles? It constricts blood vessels. But it does another thing too, which is what happens is not only does it reduce swelling by constricting blood vessels, it also does this. The walls of the airway get wider. Why does it do that? Because epinephrine is synthetic adrenaline. What does adrenaline do to you? It gets you ready for fight or flight. What would you like to do? What would you like your airway to do when you're trying to run away from a tiger or face off against your competitor for whatever it is that's rare and precious to the both of you? You want your airway to dilate to get more air in and out to get ready for the action. So adrenaline, among other things, is a bronchodilator, and epinephrine then is a bronchodilator, as well as reducing swelling. Okay, so when can you use it? How can you use it? That's your protocol, and for that you would want to continue filling out your fact sheet that I uploaded for you. Great way to study. What else does adrenaline do? What does adrenaline do to your heart? It makes it go faster. What does adrenaline do to your blood pressure? And it increases blood pressure. So this, you know how to use this. But now, what if, and you already know this, so I'm skipping over through it. When can you give another one? Additional doses of epinephrine. When can you give a second dose? Again, refer to the protocol. The act of looking it up, that what New York State says, the act of looking it up is part of studying and help you remember it better. Additional, what if no auto-injector was available? Well, absolutely, call for ALS Intercept. But what if you don't have an auto-injector because the patient doesn't have it and you don't have it? Instead of an auto-injector, what if you have one of these things? Check and inject. And that's where this video comes in. How to use check and inject the system. 20-minute video. I think it's worth a look. Anyway, here's the link. Check it out. Okay, how about a small child? Less than 66 pounds. That is the protocol also. Then if the child is small, use half a dose, which is 0.15. Test question. And that's anaphylaxis. So that's it for chapter 20, and let's go on to chapter 21 next.